Hi, I'm Lena,
And I'm Melina.
and in this video, we will be talking about OT evaluation while focusing on the intervention planning and treatment management portion of the process. We will also touch on some of the concept maps from our first semester that we found helpful as we studied for our cadaver lab. During the OT evaluation process, one would receive a referral, review it, and conduct a screening to determine if further evaluation is needed. If so, one would gather data about the client using an occupational profile while also observing the client's occupational performance. Once these two things are done, the occupational therapist would then use standardized and non standardized assessments to further identify barriers to occupational performance, as well as identify goals of therapy in collaboration with the client. Some common assessments that one could begin with include manual muscle testing and range of motion testing. Once the assessment portion of the evaluation is done, an occupational therapist would move on to interventions and treatment planning for that patient. A re-evaluation would occur before the OT finally discharges a patient from therapy. That is the overview of the whole OT evaluation process, so Melina and I will now discuss the different sections of our concept maps and more specific intervention planning and treatment management.
While preparing for our cadaver lab, we referred back to the Otis concept maps that we made in our first semester, such as these right here. These covered biomechanical principles of bone, cartilage, and skeletal muscle, which are the foundations of understanding the human body essential to occupational therapy. Understanding kinesiology concepts helped us during our cadaver lab when performing manual muscle testing on the cadaver. By knowing about the physics and the classifications of joints, we were able to stabilize and properly apply resistance to different muscles of the hand. For instance, we know that if we are trying to test the extensor digitorum muscles of the hand, we would ask the patient to make a claw hand while stabilizing the wrist joint and applying resistance at the proximal phalanx. This gives us a greater mechanical advantage. The kinesiology concepts and understanding movement are fundamental in the basics of activity analysis in order to help a client regain the movements and strength needed to perform occupations that they need and that they love. Now we will move into more specific structures and the joints of the upper extremity. This concept map about the elbow reviewed the bones and non-contractile elements of the elbow joint. Understanding the structure of the bones of the elbow was important while learning the origin and insertion of the shoulder and forearm muscles. This knowledge will help us in the field when treating clients with upper extremity dysfunction, such as golfer's elbow or tennis elbow. This part of the concept map helped us organize the muscles of the forearm into flexors and extensors in order to organize the actions of the muscles as well as the location. We used images to help us while we were reviewing, which aided in identifying muscles in open lab. The shoulder concept map was similar to the elbow, in which we organized starting with the structures of the bones and the joints. The organization of the shoulder muscles is unique because of the multiple joints involved. For example, these muscles are grouped by axioscapular muscles, axioclavicular muscles, scapulohumeral muscles, and axiohumeral muscles. Like the shoulder and elbow, we tried to follow a common grouping pattern with the wrist by starting with the bone structures and then moving on to the distal radial ulnar joint and muscles of the wrist. For the wrist, we looked at the specifics such as the carpal bones and the different rows such as the proximal row and the distal row, which helped us understand the origin and insertion of some of the intrinsic muscles of the hand, and then the details of the metacarpal bones and the phalanges. It's important to understand the bony landmarks, which can be palpated. Examples are the radial styloid process or the ulnar head. and understanding the types of joints that are in the wrist and in the hand and the digits. In addition, the muscles of the forearm can be organized by superficial muscles and deep muscles. They can also be organized based on which side of the hand they're on, so the volar surface or the dorsal surface. We can also look at combined actions of the wrist muscles and synergistic functions of the forearm muscles.
For the rest of the concept maps, we will incorporate interventions and treatment planning into the discussion. At the wrist, the carpal tunnel houses the tendons of the FDP, FDS, and the FPL, as well as the median nerve, and is a common site of impingement, causing inflammation and leading to carpal tunnel syndrome. Some repetitive occupations that could cause CTS include typing. As far as interventions for CTS go, one would first and foremost recommend the client to rest the area and provide an orthosis if needed. After resting the area, the therapist could then educate the client on behavior modification. For measuring grip and pinch strength, an evaluation tool that one can use are the dynamometer for grasp and a pinch meter for the 3 types of pinch: lateral pinch, tip-to-tip pinch, and 3-jaw chuck pinch. Dexterity measurement is also important as it could help or hinder a client in their ability to manipulate objects for riding, fastening their clothing, or turning a key in a car door. Lastly, Chapter 22 talked more about sensation. Although we are learning bone and joint structures as well as muscles and tendons, it is very important to consider the innervations of the muscles. Nerves have 3 functions: motor, sensory, and sympathetic. This chapter really helped when thinking about what could happen to someone with loss of protective sensation. There are 5 mechanisms of damage to insensitive limbs: continuous low pressure, concentrated high pressure, excessive heat or cold, repetitive mechanical stress such as CTS like we talked about above, and pressure on infected tissue. This chapter really honed in on passive and active sensory training for clients with peripheral nerve injury as well as clients post-stroke. For clients post-stroke, a therapist could start out with passive sensory training by using repetitive stimulation, such as electrical stimulation, based on evidence of cortical reorganization in response to repetitive stimulation. Once moving into active training or sensory re-education, the patient is more involved and interventions such as mirror therapy could be used. This is based on the concept of neuroplasticity in learning. The goal of passive and active treatment after CVA is to gain a larger cortical representation for the areas of skin for which sensory feedback is crucial to performance of daily tasks.
In this video, we have reviewed the OT process, the biomechanical principles of the body, the kinesiology concepts associated with the science of movement, responses that produce movement, joint classifications, and specific structures such as those in the elbow, shoulder, and wrist. We have also reviewed the ways to measure strength in the hand while considering sensory aspects of it as well. Overall, concept mapping has helped us apply the information that we've learned in our undergraduate degrees, our prerequisite courses while applying for OT school, our foundational courses in the first semester, as well as our second semester courses which built upon those foundations and helped us understand the OT evaluation process, ways to administer assessments as well as ways to select assessments, and also understand the ways to create goals and begin to implement a treatment plan. We can use this information, which also ties in our new knowledge, our knowledge that we've learned in our cadaver lab, and help us in memorizing information but converting it to long-term knowledge that we can use in field work and as we study for the board exam and later in practice.